Oh, okay. So thank you everyone. Thank you, Multicultural Students Affairs Office. Thank you, Ivan Ramirez, for hosting this talk, and of course, thank you, Dr. Rebecca Singer, for being with us today. Thank you so much. I am Dr. Alberto Villamandos. I'm the chair of the Foreign Languages Department, and we have created this series of talks about different topics. Our first talk was about heritage speakers, Spanish heritage speakers, by Dr. Kim Potowski. Our second talk was about migrant students returning to Mexico in the school system in Mexico, by Professor Gabriela Boylan. And today we have this afternoon we have a talk more related to health sciences, but also with languages, and how health sciences has this international aspect that is really, really important, especially, I mean, it has been always important, but now with the pandemic, I think it affects uh, billions of people. So I think many of our students who are language majors or language minors, they are also pre-med, pre-nursing. They're interested in health sciences in general and psychology. They will find this talk very, very interesting, very appealing. So let me introduce our speaker tonight, Dr. Rebecca Singer. She earned her nursing doctorate from the University of Colorado, Denver, and her doctorate degree in nursing practice from the University of Illinois at Chicago, where she also teaches population health, a field she has been an expert for over a decade in its global and community aspects. She has also worked for over 75 months in the field with the humanitarian response organization Doctors Without Borders. And most of her work focuses on providing care to survivors of violence, establishing primary health services for displaced persons and refugees, responding to epidemics, and establishing emergency preparedness. Dr. Singer has also worked with Grounds for Health, establishing community-based cervical cancer prevention programming in Latin America and East Africa. As the executive director of Coffee Kids, she partnered with coffee cooperatives to improve the lives and livelihoods of their coffee farming members and their families. Formerly the director of healthcare services at an interdisciplinary center for torture survivors in Denver, Colorado, Dr. Singer provided intensive healthcare case management to asylum seekers and refugees. Additionally, Dr. Singer is involved in a UIC project to bring nursing students into correctional facilities to engage in health promotion activities with the individuals detained there. She's also part of a team developing an online curriculum that will prepare healthcare workers to provide care within the corrections system. Dr. Singer is committed to ensuring that healthcare workers engage in self-care that enables them to maintain high levels of compassion, satisfaction, and avoid compassion fatigue, burnout, and long-term impacts on secondary trauma. She believes that continued engagement with the arts and humanities, I really love this part, has great potential to help healthcare workers find meaning in their work while enhancing wellness. I cannot agree more with that. Thank you so much, Dr. Singer, and I'll give you the stage.
Thank you so much. I'm so happy to be here. I so enjoy speaking with students from all over, and it's fun to get a perspective of students from a different university and from a wide variety of disciplines. You know, I get sort of pigeonholed into my ivory tower of Chicago-based nursing, but so it's great to see this wide variety of students. If people can use their little hand thing to show who thinks that they're interested in doing global work one day. You can use your little emoji, your hand emoji, any hand emoji, yeah. So, yeah. Great. So lots of people here today are interested in doing global work. So today my talk will focus on the work that I have done. I'm going to share my screen right now. Can folks see it? Okay, great. Okay, great. We're going to talk about my work that I've done in global health and how having a facility for languages or just a desire to work in different cultures and having that sort of engagement can become a career. And that, I was a kid who read and wrote and looked at the atlas. And I thought, like this, I was traveling the world through books and through maps. And at some stage, when I was quite a bit older, I mean, I'd been out of college for a while already, I sort of started focusing on like, oh, I could make that a career. Like I could do healthcare services globally. I could provide care to people who are suffering and help to alleviate that suffering. And I think that if I'd been told when I was your age, or I don't know that you're all that age, but university age, that I would become a nurse one day and work overseas doing this work, I would have just been like, nurse? I don't think so. I'm too bookish to be a nurse. But in the end, I found that nursing and what nursing is and how we connect with humans is really appeals to that side of me that is interested in the humanities and the arts, and then appeals to that humanitarian side of me and what drives me. And I was able to create this career in global health that has really fed me and hopefully done some good in the world as well. So I'm going to talk a little bit about the humanitarian work I've done with Doctors Without Borders. So Doctors Without Borders is a medical humanitarian organization. And when we talk about global work, there's humanitarian work, and then there's often development work. And so they're quite different. Development work, if we were in the classroom, I would make you guys figure this out yourselves, but it's hard to do some of that engagement on Zoom. So I'm just going to talk at you. So development work really is concerned with recreating and changing systems. Now, we all know we have a ton of work to do on this in our country, right? It's like the work that we need to do to stop structural racism and structural violence and to rebuild. That would be development work in our country, right? Humanitarian crisis work, humanitarian response work, is the stuff that we do to respond to the crisis at hand, right? So that's the work this year. We're doing that for COVID. So over here is the development work that we need to do to rebuild our society in a more just manner and to dismantle racism and structural violence. And over here, we're doing the humanitarian work of responding to the current crisis, which really is COVID-19 and its impact. They're related to each other, right? We can't talk about structural racism and or COVID without talking about the other one. But in our responses, we're doing two of them. We're doing their sort of different ways of approaching it. So most of my work has focused over here on responding to global health crises with Doctors Without Borders. And when we talk about global health crises, we're talking about human-made and natural disasters. So that can be floods, it could be earthquakes, or it can be war or famine or epidemics, which are, and some of those are a combination of human-made and natural disasters. But when we talk about terrible sort of inequitable impacts of them, that is human-made. So when we talk about humanitarian response work, I like to quote James Orbinski, who was the head of MSF at the time that Médecins Sans Frontières, MSF, won the Nobel Peace Prize in 1999. And in his acceptance speech, he said the following: "Our action is to help people in situations of crisis, and ours is not a contented action. Bringing medical aid to people in distress is an attempt to defend them against what is aggressive to them as human beings. Humanitarian action is more than simple generosity, simple charity. It aims to build spaces of normalcy in the midst of what is profoundly abnormal. More than offering material assistance, we aim to enable individuals to regain their rights and dignity as human beings." And for me, this really encapsulates in words far more beautiful than I could ever put together why I do the work I do and what this work is really about. Yes, it is about vaccinating kids. It is about preventing or addressing malnutrition. It is about, helping that mother, that child, that father who has HIV, TB, Kala Azar, who's been raped, who has malaria, whose home was destroyed, who fled a war. It is about all those things. But more importantly, it is about helping them regain their rights and their dignity as human beings. And very importantly, it is not contented action. I love my work. I am passionate about it. I wouldn't want to do anything different. But man, I wish I was out of a job. I wish that we would be able to solve those problems over here system wide so that we didn't need to respond to crisis after crisis after crisis, and the sort of healthcare emergencies that arise in those crises. So MSF works under three humanitarian principles. And these are general humanitarian principles that guide most organizations' work, and they are impartiality, neutrality, and independence. Now, many people are like, impartiality is the same as neutrality, isn't it? And they're similar, they're related in some ways. So when we talk about, I'm going to start with neutrality, although it's in the middle, I'm going to start there. Neutrality is when we think about, we're not going to take sides. As an organization, we don't take sides in conflicts in most cases. And this means that when for example, when I worked in South Sudan, it meant that I was working in the northern part of South Sudan. The Nile River was the border, the front, basically, between the government forces, and the government was predominantly one ethnic group, and then the opposition forces. And in that area, it was predominantly a different ethnic group. And so these two groups were fighting each other. And MSF very deliberately put a project on the government side and another project that I was working in the opposition area to demonstrate in action how we are neutral. We don't care who's right, who's wrong. We're not going to fight this war. It's not our war. But people on both sides, Dinka or Shilluk, are suffering. So we're going to provide the healthcare that they need. And so that's how our neutrality plays out. Impartiality is slightly different, and it's more looking at non-discrimination. So while we do have criteria for entry into some of our projects, sometimes we're only serving kids under 5. Sometimes we're only serving pregnant people. Sometimes we're only serving people who are HIV positive or have TB. But what we're not doing is saying, you over there, you're from XYZ ethnic group, so we're going to serve you, and you over there from the other one, we're not. Or you are an opposition figure and you don't agree with the government, so we're not going to serve you. And you over here, we're going to serve you. And so that we don't care. We only allow people in whether they meet the criteria for the services that we offer, obviously, and that they have a need, right? So the people that we don't allow in are people wearing military uniforms or people carrying arms. So those things, we actually, in some of our projects in places that are highly armed zones, we have like little, almost like a coat check for their arms, where they'll like leave their guns or their swords and machetes in a cupboard, and they get a check. It's like a coat check. And in lots of places, we just say, like, go take off your military uniform, and I'm happy to treat that wound. But as long as you come here with that on, we can't do it. And the impartiality has, many of you might have heard about the incidents in 2015 in Afghanistan, in Kunduz, where we were running a very large trauma hospital. And that trauma hospital was bombed by NATO forces. And when sort of challenged about why that happened, one of the excuses used is that, well, you were harboring Taliban, weren't you? You allowed Taliban on the property. And MSF's response was like, we don't know. We don't ask, are you Taliban? Are you not Taliban? And so to us, what matters is, do you have need? Are you visiting a family member in this hospital? Are you here for those reasons related to their health needs? Independence plays out in that we as an organization make our own determination based on our assessment of the community's needs. So we'll go to a place and determine what those needs are, look at our resources and our abilities, and say, okay, this is what we can do to serve those needs. but we're not taking our orders from a government force over here being like, no, 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 you need to go over there in that region, and you're not allowed to go in that region. And you can only work on malaria, and ignoring over here, there's an entire population that's suffering from malnutrition, right? That's not what we're going to do. We're going to look at the whole picture, decide what our resources are, figure out what the community says they need, and then provide what is the best thing for that, provide the services that we think that we can offer. This also, we are able to do this because we are financially independent. So we rely on donations from people like you, people like your family members, your neighbors, your friends, as well as some large donors, which some of you might be friends with those people, as well, that give large money. But small donations all the way up to large donations, we rely on individuals. We don't take money from governments, or very rarely. And we're very careful about what institutional funds or foundations that we'll take money from. We don't take money from governments because we don't want foreign governments. So the United States government, for example, we do not take funds from. Because the United States is implicated in many of the wars in which we're trying to address needs. And the second thing is that we don't want to deal with the restrictions that the US government might offer. A classic example of this is in reproductive health care services. So the United States says you can't offer any care surrounding abortions using US funds. You can't talk about it, you can't provide the service, you can't refer people to the service. Well, abortion is a healthcare need. It is something that women often is life-saving and life-preserving. And so we're not a pro-abortion organization or an anti-abortion organization. We are pro-family, pro-person, pro-patient. And so we're going to offer that service. And so if we took US funds, we wouldn't be able to do that. So we don't, we decide what the healthcare needs are. And so those are the main principles. And then overriding them all are health ethics. So, we work where most of the places that we work, 90% of our staff come from that country. So when I work in Congo, 90% of my colleagues are Congolese. When I work in Cameroon, same. When I work in Haiti, same. So we're talking across languages, we're talking across cultures, we're talking across experiences, we're talking across the training that we have. But what overrides us are those ethical principles that help us as healthcare providers to make the right decisions together to meet the needs of the population that we're trying to serve. So what does this look like in person or on the field, in action? So we basically do two things. We respond to emergencies, and then we also bear witness. So let's start with responding to emergencies. This is probably what you imagine when you think of MSF. You think of like a bunch of people in white t-shirts and with a little red running man sort of symbol running and serving people who are in need. And that is a lot of what we do. We mostly provide primary healthcare services in places, that's the biggest bulk of what we do is emergency response services in terms of primary care. So that's your basic healthcare needs, meeting people's basic needs. Sometimes we also arrange for people to get higher level needs. So, we'll provide care that will help deliver babies, help treat the flu, help treat infections, injuries. And if things happen that we can't provide that care on the field because it requires a surgical services or it requires a higher level of care, we're going to facilitate referral, if possible, to a higher place, to a higher level of care. So that's one thing we do. We also do provide care, access to care for diseases or problems that are not met by local healthcare systems. So there are lots of places where not as much anymore for diseases like HIV, but a long time ago, places were not providing care for people who had HIV. So that's one thing that we were able to do is to develop ways of providing that care that and increasing access to that care in a quality way, even in a very low resource setting, and demonstrating how it could be done. We do this with tuberculosis. We do this with diseases that are forgotten diseases like Buruli ulcers or Kala Azar. You've never heard of those things probably, and that's okay. I hadn't either until I started doing MSF. But these are tropical diseases, forgotten diseases, things that we don't necessarily see in the United States, but then can cause long-term disability and even death, but that are very treatable with the right resources. So we'll do that. or certain things that we do are treating sort of more social conditions. So I've done a lot of work on sexual violence response or domestic violence response and providing care to people experiencing violence in that way. We're also known for responding to epidemics, right? There was a lot of, we were among the organizations that launched an enormous response against Ebola in the past 2 Ebola epidemics. We're also I've been on cholera vaccination campaigns. I've responded to measles and vaccinated children for measles. So going out into like the most remote regions, getting in cars and driving to the ends of the road and then putting things on motorcycles or putting them on people's backs and walking through the woods to get to small villages to make sure that kids are vaccinated against measles. Measles kills people. And it's easily preventable, right? And so that's a lot of the work that we're able to do, is to get to that beyond the end of the road to provide those services. And then finally, we do a lot of work with mental health services. We believe that there's no health without mental health. When I first started with the organization back in 2005, mental health services were really niche, and they were really for sexual violence and for TB and for HIV. That was it, like very low level. And now there's really an understanding that it needs to be integrated into all healthcare services that we provide, right? So just like we can go to our provider and say, I'm feeling kind of down, and they're going to assess our mental health, and they could perhaps prescribe medication, or they can prescribe some sort of treatments, or recommend we go speak to a therapist at our primary care provider, right? That direct entry, MSF believes the same thing these days and is really trying to be able to provide those services to everyone who needs them. I was in Cameroon in 2018 when there was a civil war breaking out. It was I was there in the very early stages of the war, and it went from being a very peaceful country, people leading very comfortable middle class existences, very successful farmers, coffee farmers and chocolate farmers and lawyers and teachers and doctors and nurses, and really comfortable sending their kids to university. And almost overnight, their lives were destroyed. Their communities were burnt down, and they were forced to flee to the woods. And we went down to do an assessment, and we're trying to figure out what people needed. And, we sort of have in our heads, like primary care, and then dealing with pregnant women or pregnant people and small children. Like those are the things that we mostly do classically. And I remember getting on the phone with headquarters and saying, they're saying to me, the midwife is ready to come. And me saying, we don't need a midwife. We need a mental health officer. Most of the people we're seeing are suffering from mental health conditions and from trauma. And that's what we need to deal with. That's what's going to bring the most bang for our buck in this place. And that's great to have seen over the past decade and a half. And secondly, MSF is known for bearing witness. When we were first founded, now we think like, well, of course you advocate, and of course you do that advocacy work hand in hand with the humanitarian response work. But at the time that we were founded in the 1970s, that was not the norm. Organizations either did advocacy or they did healthcare services. MSF is committed to doing both. I've been really lucky to be able to be involved in writing several advocacy reports, in particular one in Liberia and one in Papua New Guinea, in which we took our experiences dealing with survivors of sexual violence and then sexual and family violence in Papua New Guinea, and being able to document what the experiences of our staff, the experiences of our patients with their permission, having them tell us their stories, and then talking to them saying, what would you want your government to do, to helping us to craft a message that we can present to the government. And in both cases, we were able to change policies, we were able to change procedures, we were able to change how donors provided funding to different organizations in order to better respond to the needs of the community as we had seen. So that's what the principles look like in action. As you can imagine, there are lots of challenges to this work. And one of the main challenges is that the impact is limited, obviously. When we're working in humanitarian response, we're talking, we're not looking at changing, right, the system, but we are looking at that real temporary, like we're going to solve this problem now. And sometimes that lasts for years because war is messy and lasts for years in many places. But really, ultimately, we're always one foot out the door trying to figure out how to get out. And we're not looking to change those systems. So that can be really challenging for people, especially people like me who think in systems. Also, oftentimes we can't fully heal or cure. It really is just relief. And that can be challenging. And oftentimes we are forced to give substandard care, not because we don't think that people who live in Cameroon, South Sudan, Congo, Papua New Guinea deserve anything less than I deserve living here in Chicago. It's really more complicated than that. And it's really focused on access and how, infrastructure. So, first of all, sometimes governments don't allow the best sort of World Health Organization protocols to be input because for whatever reason, they want a different protocol. Or sometimes the best drugs are not approved in a country, and so we can't import them. Sometimes we can't get our things out of customs because they want us to buy it locally, but we don't trust the local supply chains. So we're trying to import things, and those things get stopped at the border. Sometimes it's really simple. Simply weather, right? I worked in South Sudan in a place that was super remote. You either had to fly in or you flew into an airport with a tarmac runway, and then you had to get on a boat down the river. Well, the river got closed. It was the front line and it got closed. So we had no river access. But our airstrip would only be landable when it hadn't rained. So if it rained, it took 3 days for it to dry. And as rainy season got more and more severe, it was just wetter and wetter and wetter. So we had no way in and no way out during that period. And so as you run out of supplies, you make do with what you have. It's not that I wanted to give substandard care, it's that we started running out of the necessary goods. So oftentimes it's really these bigger picture issues that can prevent us from providing the care that we need. And it gets to the fact that I have always really strongly believed that whether you live should not depend on where you live. But unfortunately, what we know is that that is the case both abroad and also here. When we talk about our zip code is more impactful on our health and our health outcomes than our genetic code. Um, Another big challenge is that we work in a broken space. When you work in a war zone, when you work in a place that has undergone a trauma, a cataclysmic event, then that is a broken space, right? And that can be really challenging to work in. One impact of that is that humanitarian space is disappearing. As I said, that there was the hospital that was bombed. I've worked in places in which healthcare workers, we've been targeted by rebel soldiers, by government forces, our health facilities have been targeted, that there's a lot of danger. And this is for a couple reasons. One is that if you stop outside interests, if you stop outsiders from witnessing, from bearing witness to what happens, then anything goes. So you get the outsiders out, and then you are free to do whatever you want. No one can see it. Another thing is that it increases the suffering of the population. If you get rid of the healthcare services or the malnutrition program or the person who's building the wells, then that can be actually a really strong weapon in the war in which you deny people access to things that they need to keep their lives going. And then finally, and this is a little bit more complicated, is that as war has evolved, it's very hard to see who the humanitarian actors are and who the military actors are. So I'm going to play, for example, in the United States, when we were fighting in Afghanistan and Iraq, we sent our military in to fight, but we also sent our military in to build healthcare centers and to build schools. So if you are someone from Iraq or someone from Afghanistan and you see a person who is white, a foreigner, doesn't necessarily speak your language, is clearly an outsider coming in, and they are building a school on Monday, but on Tuesday they're bombing your village, it's very confusing, right? Are they helping or are they hurting? And when I come in, they don't know that I'm not with them. All they know is that I also am a white stranger coming in. And so humanitarian workers, that humanitarian space has shrunk as militaries have tried to win the hearts and minds, as we said at the time, by doing that sort of those actions. And so it does make it more unsafe for people like me to do the work that we do in the communities. Also, we are working with and for traumatized communities, and that's challenging, right? So as I said, most of our colleagues are from the countries in which we work. And so really my colleagues are experiencing the same trauma that we are addressing. And it's just ever present, right? And very challenging. For me to be like, you need to be at work at 9 o'clock. And what they're trying to do is feed their family, find food, get to work safely, make sure their kids are safe. Those are really challenging things in a war zone. And there I am being like, work starts at 9. And it is important for work to start at 9. People are coming to our health center because they need help. But it can be really challenging when when our beneficiaries are also our colleagues. And then finally, really that focus on the humanitarians and not on the humans. We often talk about the daring do of organizations like MSF and the amazing work that they do. And then we don't focus on actually the impact it has on humans and the suffering. We're only there because of geopolitical and economic and philosophical and ideological decisions that are being made and forces. And so let's focus on those. Let's focus on the people who are impacted by that and why they're being impacted by that. And let's try to work to change those systems as opposed to talking about how amazing it is that this organization does this great work to meet those needs. Let's think about, we should be thinking about changing that structure, right? We shouldn't be thinking about the Band-Aid, but we should be thinking about healing the wound beneath the Band-Aid. And then finally, the personal is professional and the professional is personal. This work is all consuming. When you're overseas and working in a remote region of Congo or in Papua New Guinea or South Sudan, and mostly I have really worked in remote regions. It's the work that I really love. It can be really isolating. I work in places where there is no internet, or there is no regular electricity. I work in places where the ICU, intensive care unit in my hospital means that we have a machine that makes oxygen that we can run when we run the generator. Places where we don't have a refrigerator, where we don't have running water. And that can be really isolating. It's fun. It's super fun, but it can be really isolating. Like I told you about that place, like the planes weren't coming in and out, the river was shut down, the planes weren't coming. So you're isolated in that place. And maybe you can't leave at the end of your project, at the end of your contract, because it rained. Also, you're professionally often quite isolated. I'm often the only nurse, the only expert in sexual violence, the only manager, only person of my sort of narrow expertise or narrow work doing my work, and just trying to rely on my wits to do that. That I don't have the colleagues that I have when I'm working here, where I can turn to one of many, many, many people to get advice and input. It's often in the moment trying to MacGyver it or to try to figure out how to solve that problem on the fly. Other issues that come up is obviously that with this work that you have to be careful about not having that white savior complex. So that idea that I am Western educated, I have this fancy degree from the University of Missouri in Kansas City, and I know everything because I learned it in my anthropology class, and I am amazing. That's all true. You are amazing. And I have to remember that my education and my experience doesn't make me the person who's going to be able to solve that problem in Congo, where I don't speak the language very well. I don't speak the local languages at all. I speak a smattering of Swahili. I speak French, but I am not from Congo. I don't understand Congolese culture very well. I don't know a lot about malaria. I mean, I've learned, but these are not the types of patients that I'm used to taking care of in terms of disease processes. So really what I have to offer is my sort of global knowledge, my ability to organize, my ability to support the people who do know how to do the work. But if we come in there thinking like, I'm going to solve the problem because I got my big fancy Western, upbringing and education, we're going to fail because we're going to turn people off. And so really trying to break that colonial experience and really trying to turn that and make it a collaborative process where we all bring something interesting to the table that we can work together to meet the needs of this community as they express it, as opposed to coming and imposing another form of colonialism in the places that we work. And then finally, when we talk about humanitarian workers, we can talk about people who are either, they do it because they're martyrs, mercenaries, mystics, or misfits. And so it's always good to examine what type of person we are and what our motivation is for doing the work that we do, and which person we are at which given time, and why we're drawn to this sort of work. I just want to say that, when I've done this work for well over a decade, for a decade and a half, and I was guilty of hubris and thinking that this was work that I did far away and over there, and that the shortages that I would see in supplies, the sort of very disorganized central government response, poor infrastructure, poor myths about, people not believing what's happening and why it's happening, that those things happened over there in countries that were far away from my home. And at the end of the day, I got to go on a plane and I got to come back to my nice, comfy life in Chicago. And in March, it became clear that, in fact, I had misjudged that, and that the humanitarian crisis came crashing down on our shores. It became clear that how we have responded to a major global pandemic has been no different than how the government or the people of Cameroon respond to a civil war there. It's all the same sort of challenges that we've had. And I've been able to bring my skills here. I've been working on a couple COVID response projects. I established a testing center for employees of University of Illinois Health Center. And now I work doing COVID response in what are called congregate settings. So doing testing for the city of Chicago in shelters for people who are undomiciled, for people living in residential treatment centers, for people in correctional institutions, and for people living in long-term care facilities and youth facilities. So anyone living in those congregate settings, which are, obviously it's very difficult to social distance when you have a large group of people living together and working together. And so we're doing testing to try to identify clusters and to bring people the care that they need and to isolate them to try to protect the whole community. So every single day, it's like being on an MSF mission. Every single day, I get in my car, go to a new location, put the bins, all the equipment in my car or one of my teammates' cars. On a new place, we meet the needs of that population by testing as many people, dispelling the myths, treating them with loving kindness and competently, and then packing it all up and going to a new place the next day. And it's been it's been extremely humbling to see that, in fact, our country is no different, and the people of our country are no different when it comes to these crises. But it's also been very exciting for me to be able to use the skills that I've developed in my career in order to help the humanitarian crisis in my own city. All right, does anyone have any questions?
Thank you so much, Dr. Singer. I think this is an eye-opening uh, discussion and lecture. Dr. Lindsay Myers, my colleague in French, she had to go, but she had a question that it's related also to my field. It's how cross-cultural and linguistic competence, or the lack of,
Mhm.
potentially change outcomes in global work at
Oh,
small or large scale.
yeah, that's a great question. So I'm going to stop sharing my screen so I can see folks. Um, yeah, that's a fabulous question. So I think one thing that, because I do speak languages, I have had opportunities to work in places that I wouldn't necessarily get to work. So I have been able to work in Francophone African countries. I have been able to work in Latin America because I also speak some my Spanish. But also, like, the fact is like, I speak these languages fine. My French is more fluent than my Spanish ever was, but like, I miss so many things. I was saying to I was working in Congo, and I was going to a very, very, very remote region. And with me and 9 Congolese colleagues were going to respond to a malaria epidemic. And it was in a place that was, you know, basically like a 5-hour motorbike ride and a 6-hour walk from our base, and really deep in the middle of nowhere, so not very easy to get in and out of. Only satellite in terms of um, security, and in a place that is unstable. Like, we know that there's instability and militias in the area. And I said to my colleague, who was like the boss of the project, I was like, I'll be fine. You know what? Like, I understand 80% of the French. I was saying, and I was like, I understand 80% of the French of everything that happens around me. And he's like, yeah, but what happens in that 20% that you're not getting? That's what concerns me when we're talking about security. And I was like, right. So I do lose something, right? Like, first of all, I mean, and that's a very extreme example of like, it could be a matter of my safety, but it's also a matter of how I'm connecting to people. I also often joke that I speak French with a machete. I don't speak French with a scalpel. Like, when I speak English, I have a scalpel, right? Like, I can really refine my language to be very specific to the needs and communicate that. When I speak French, it's a machete that I am like wielding. And so I'm gonna be a little bit more dangerous. And I think the one thing that I've always done is that I start with the sort of self-deprecation about like, my French is terrible. My French is a joke. Like, sort of start there. My Spanish is awful. Please, please, please excuse me if I have to ask for things twice. Like, really starting with that sort of putting myself on a different level, and not walking in being like, I got this. And so I think also walking in, recognizing that I'm going to be missing a lot is really, I think, walking in with that attitude. So that I do ask questions, and I do try to bridge those gaps. Now, the other thing is like, when you are working in places like this, you really have to be willing to rely on the expertise of the people in the place. And it gets to that sort of white savior complex and that attitude that we often have, like, but I have a doctorate. Actually, I have 2 doctorates from the, in the United States. Well, of course I must know everything. And the fact is I know nothing about South Sudan or about Papua New Guinea. So if I also walk in recognizing that, and being willing to be the cultural naive and learn, then we're going to be able to bridge those gaps, because then people are going to be willing to tell me when I have it wrong. And so I think that I think for me, a big part of that cultural competency or cultural humility is actually building those bridges so that people can tell me when I got it wrong, and I can own that and listen to it and hear it so that I can get it right. But it's challenging. But it's also what makes it exciting to me.
Thank you so much. Any questions for Dr. Singer? Comments?
Yes, I had a quick question. So is there a way to be involved only temporarily? Because, for example, for me, I would like to work here in the United States, but like every now and then go and help out when I'm needed. Is that a possibility?
Mm-hmm. That's a great question. So first of all, I just want to say that you don't have to be a healthcare provider to work for an organization like Doctors Without Borders. First of all, whatever your interest is, there are plenty of global organizations doing all sorts of amazing education work and community development work and democracy work and voting, as engineering and infrastructure development and IT. And then also all those things around IT, communications, finance, logistics, I said communications, advocacy, legal work. All those jobs are needed by MSF. We're only 40 to 50% of us are healthcare workers, and the other 50%, and depending in certain places, are non-healthcare workers who have another set of skills, including people who are sort of straddling the line as health promoters, epidemiologists, people like that. So for the work that we do ask for a 2 years of experience in your field already, so that you're comfortable. And that gets to that point where, like, you can't send a new nurse who can't make clinical judgment calls off to a place where they might be one of 2 or 3 nurses in the entire project, making, I couldn't work as a nurse in the middle of the back of the beyond of Congo, meeting the needs of people who are suffering from malaria and dying, if I didn't feel confident in my skills doing assessment and sort of guiding treatment plans, right? Like I just couldn't. So we want people who are comfortable enough in their shoes to be able to make decisions. So whatever your field is, 2 years. The second thing is that for the first project, we really do ask for a 1-year commitment. So that first project out, we want to know that you're actually willing to do it long term. And then after that, you could do shorter stints. So there are plenty of organizations that do shorter things. And I just always encourage people, when you are looking at organizations to work for, that you really look at the mission statement and make sure that you agree with the overall mission of the organization, how they work, that their sort of values align with your values, and that the work that they do is actually the work that they do, and that in some way they meet demonstrable needs in a way that is safe and effective. And so, you know, there are so many organizations out there that, you know, go for shorter periods of time, that use different skills. And so just making sure that when you're choosing those, that you're choosing things that are, that align with who you are.
Thank you.
MSF also does support university chapters. And so if someone wants to create a university chapter, you just have to look online onto the doctorswithoutborders.org. So the MSF USA website has information about creating a university chapter. And then that's a way of learning more and supporting the work of the field. And there are internships in New York office or online this year with MSF as well.
All right, thank you so much.
Yeah. Any other questions?
Yes, I have a question. Oh, let me turn my camera on.
Okay.
Hi, my name is Coco. I'm currently getting a BSN here at UMKC, and my former undergraduate degree was in global health. So I'm trying to bridge the gap between global health and nursing. And I'm actually from the area in Cameroon that you were in. And I wanted to know if I could work there with you guys, or if that would be some sort of conflict of interest. Because I know with the Peace Corps, they said if you are anywhere that you're from or you have family, they don't really want you working there. But I feel like because I'm from there, because I understand what's going on, I would provide a unique, I guess, point of view.
Mm-hmm.
So yeah, that was my question.
Yeah, that's a really interesting. Yeah, that's an interesting question. Are you from Southwest or Northwest? Just curious.
Southwest.
Where I worked.
I
Yeah.
know.
So it can be complicated. And the reason I can't give a straight up yes or no answer is that especially in some of these conflicts, are so complicated that you actually don't know who and what could actually be triggers and can actually decrease the security of your team by their very presence. So, for example, and I'll take it away from your specific sort of situation, but there are lots of places that people from the United States with a US passport cannot work. And the reason we can't work there is because our very presence puts the entire project at risk in terms of that an American citizen, because we are combatants in the war, the US government is the combatant in the war. So in places like Afghanistan or Iraq or Yemen, where we are implicit in what is going on, that on the ground, they're not going to be like, oh, she's American, but she works for MSF, so she actually must be okay. And she must really be supportive of our point of, that's not happening. It's just like that person has a US passport, so they could be a target in terms of a security risk, especially in places where humanitarian workers are targeted as where they're targeted. So that would be a piece that could complicate things. And that I think in lots of places, especially war zones, I think it makes it more complicated. Now, if it's a non-war zone and it's not that sort of thing, and it's just like, a place like Malawi, for example, where we have HIV projects, then that's a really different situation where having the language skills and stuff like that is probably less of a security issue and just more like, sure, no problem. So I think that it's complicated. Also, just MSF likes to hire people and match them. So Coco, your skills as a nurse might actually be like exactly what we need in, in South Sudan, actually, because you have a niche thing, and what we need in Southwest Cameroon or in the refugee camps in Nigeria is really, really different, and it's not a good fit. So we want to be able to make those matches. Does that answer your question?
Yes, thank you.
Also, I will say this, for an organization that really believes in impartiality and neutrality, the mere fact that you have probably a viewpoint about the conflict, which is extremely strong and virulent, and like that you might have an opinion that makes you not neutral and not impartial. And that would be another risk of allowing people, placing people in those situations.
Okay.
Yeah.
And how can we get in contact with you after this, if that's like an option?
Yeah, Alberto has my email, so
Okay.
yeah, I'd be happy to share it.
Thank you.
In the chat. That's also possible. All right, other questions?
I'm just curious about what's the impact on mental health for those people who work for Doctors Without Borders when they come back. Like do they, because they must see any kind of situations, right? So do they have to? I mean, what's the process of coming back and going back to a normal, 9 to 5 job? I don't know, like how does it look like?
Yeah, that's a great question. And I think that it's multifaceted. So first of all is that when we, there's always a period of time that they offer us health insurance that allows us to get access to some mental health services. They're very forward thinking and very open about like, this adjustment will probably be difficult or could be difficult. And we do recommend that you access mental health services through our employee assistance program. We also have what is called a psychosocial care unit. And so we can access to talk to someone from that unit that will be able to provide some level of support or hook you up with other people. It can be challenging. And I think that one thing is that when I first came back after my first project in Liberia, and it was very heavy, I was working with survivors of sexual violence. The thing that was really striking to me is like, I could never go back to work in a hospital in the United States where I have to answer to all sorts of hierarchy after having been in a situation in which it was a much more flat hierarchy, and we all had access to the people who are running the hospital, and we were all involved in the planning and really felt engaged with all aspects of the project. And so for me, it really changed my ability and sort of the trajectory of my career in some ways, in terms of what types of situations and work environments I can work after having those experiences. But also that, we talk about an issue, a phenomenon called compassion fatigue, which is somehow related to burnout. And it's sort of that idea that you, by giving, working in a giving profession and giving so much, that we deplete ourselves and we become burnt out, or we experience what is called secondary trauma. So that's when we ourselves might not be survivors of trauma specifically visited upon us, but that the witnessing of trauma over and over and over again and sharing in that trauma. So you take care of patients who have gunshot wounds, you take care of patients who are raped, you hear these stories, that can start having an impact on you. And I think it's really important to acknowledge those things, and as well, the trauma that we ourselves as primary survivors of trauma can experience when you're working in a war zone, and things that happen when you're working in a war zone. That it's really important to acknowledge that and to take the time when you do come back to deal with those, and to avail ourselves of the resources that are available, and also to just, I think, just the acknowledgement that there's been in the past sort of an idea that, like, if you do this work, you have to be a cowboy or a cowgirl, and you have to be strong, and you have to just move. And I think that it's really important to actually acknowledge that, like, this is human suffering, and having proximity to suffering like that can have an impact on one.
And is my final comment. What do you think of, you guys bringing all this help, all this support to the countries and vaccines, right? When we have movements against vaccines in many countries, including the US, like you said, like missiles can kill. Like so many diseases can be treated, but it's in the irony of that, right?
Yeah. I always say when I talk about the work I did, so in Congo, Democratic Republic of Congo, we did 70,000 vaccines in like 10 days. And I always sort of like jokingly say, and no adverse reactions, those kids, they're all fine. Sort of like that anti-vaxxer movement, like these parents are lining up to bring their kids through the rain to be vaccinated, and yeah, it's very interesting, right? It can be ironic that we're having these cultural fights in our country right now about basic healthcare needs.
Araceli, do you have a question? You're muted, Araceli. Yeah.
Oops, I am so sorry. Yes, Dr. Singer, thank you for such an informative session. I've really enjoyed myself. And one question that I have is, I assume what you have to go through a rigorous physical exam every time you go overseas. What sort of physical exams will a student expect to go through before before applying to go over abroad?
That is a good question. We do need a sign off from our healthcare provider, basically saying it's like 7 questions. It's like, can this person, are they physically fit to be able to sort of live in rough conditions? Yes. Do they have a medical condition that would be difficult to treat in a remote region? Understanding that this person might not have access to regular medications and stuff like that, would you feel comfortable sending them to a place like that? Plus, yes, you need to get a whole battery of vaccines. So basically, have the vaccines and the medications against the diseases that are endemic to the area that you're going.
Well, thank you so much for exposing yourself to this wonderful and amazing job that you do. And you're making such a big difference in the world, in so many lives.
Oh, thank
you.
Thank you.
Thank you. Thank you so much, Dr. Singer. Thank you, everybody, for coming. Let's give him give Dr. Singer a round, or at least a virtual one. Where's the icon?
Oh, yes.
There you go. Reaction. Yeah. Thank you. Thank you so much. Thank you so much. That was a great discussion.
Yeah, thank you so much. And everyone, please take care of yourselves. Please be safe. And take care of yourselves. These are difficult. So take care of yourself physically and mentally as well.
Yes, you do the same. Thank you.
Happy
Thank you. Happy Thanksgiving, everyone.
Happy Thanksgiving. Bye-bye.
Yeah. Are we taking a photo?
Oh yeah, we always take a photo.
Yes, we need to take a photo.
Well, the people. Let me see. Okay. Oh wait, let me stop the recording first. I
Okay.
forgot.
Okay.
Isn't